Hi, everybody. It's Karen Anderson here with Aortic Hope, and this is our live Q&A with Dr. Ben Youdelman. We're so excited to have you here. I told you before the last time we spoke, which can you believe it was a year ago? It was like this time last year, was and has been the most popular live event that we've had. So it's just the charm. It's just the charm. It's not the content.
It's the hairline. Any
What
receding
it is.
hairline gets a lot of attention.
That's what it is. Before we get started, everybody, I will ask you to please like and subscribe wherever those buttons are on your screen. Just like and subscribe, hit the little bell button so that you are notified every time we go live with events like this. And you have an opportunity when we're on here live for the next hour to ask your comments, ask your questions in the comments, use that comment button. And there should be a link also if you'd like to do that anonymously. And we will take questions periodically as we're talking, but we are here tonight to talk about everything aorta. Okay. Like we haven't talked about it a million times. But before we get started, Ben, why don't you go ahead and just give everybody a little bit of background about you?
So my name is Ben Youdelman. I am Karen Anderson's consummate assistant. I am a heart surgeon and aortic specialized surgeon. I work at Maimonides Medical Center in Brooklyn, New York. The focus of my work is about 50% complex and specialized aortic and endovascular aortic surgery. And then the other half of my work is coronary bypass surgery, valve surgery, and a mix of other general cardiac surgery procedures. My involvement with Aortic Hope and with Karen Anderson has been a whirlwind of educational, camaraderie, outreach, and really just fantastic relationships with her and her team, as well as all of you. And I'm really happy to be back as your guest for the second time. And thank you again for having me. I really appreciate it.
It's all very exciting. What's even more exciting is when somebody has no idea what the aorta is, which that happens a lot until there's an emergency and then somebody's like, what's an aorta? So let's start off with aortic stuff 101.
Aortic stuff 101. So there's a heart, and out of the heart, the blood goes into the aorta. And the aorta gives rise to every single blood vessel in the entire body. And you can imagine, if there's a problem with the aorta, there's a problem. And the key to understanding the concept of the aorta is that it is one organ that starts at your heart. It goes up and down like a candy cane, and then it heads into the belly and splits into two and goes into your legs. Along the way, it gives rise to a whole bunch of super important blood vessels to your heart and your brain and your arms and your spine and all kinds of good stuff. And fundamentally, if there's a problem with it that we have to fix, or God forbid there's an emergency that we have to fix, we've got to keep the rest of your body alive and getting some blood flow at least some of the time, or make some concessions in order to keep the whole organism alive. I know no one likes to be referred to as an organism, but when we talk doctor talk, that's how we do it, because it really makes it very easy to understand, as opposed to it's very difficult when you're talking about people's personalities and their families and stuff. So we break it down into very simple stuff. So that's what the aorta is. And when you have problems with the aorta, they usually come in two fairly significant forms. One is called an aneurysm, which is just an enlargement. Many people compare it to balloon. I never compare it to balloon, ever, 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 because I don't want people to have any association like that. The reason that I don't want you to have association is because it's not accurate. The aorta enlarges and it elongates and it moves around very, very slowly in the body. And the overwhelming amount of time that it spends doing this takes years and years and years to develop. And usually, if you have a family history and somebody mentions it to you and you are in communication with your relatives and you get checked out, this gets found and followed by people like me. The other possibility is a tear. And the two things that a tear can do is tear out or tear in. When it tears in, it's called a dissection, where the blood goes into the wall, tears down a length and comes back into the aorta, that is a big problem because it can disrupt these fantastically important blood vessels along the way. Or in very few cases, it can tear out, and it can tear out and go around the heart. It can tear out and go pretty much anywhere in the body. And the reason that this is such a big problem is twofold. One, it is a surgical emergency. And number two, patients present in all different, completely varied ways, from looking like a heart attack, looking like a stroke, looking like they're dizzy, passing out, like their leg is cold, like all kinds of different things can happen. You can have abdominal pain, all kinds of things, and it can all be directly related to this problem with the aorta. And that's why it is such a difficult diagnosis sometimes. And that's why we get very, very tense when we think there's a possibility. And that's why we work very hard to educate people in advance, such that they would know they have a family history, such that they could get checked out before anything bad happens.
Now, something that you said really struck me for a second, which I learned something every time we talk. But when you mentioned an enlargement or aneurysm, some doctors will use the word enlargement or mild dilation or aneurysm. Is there a difference, and how do you determine what is truly an aneurysm, or does it even matter?
So I can shift this entire conversation to a psychological discussion, in that everybody wants good news, and Americans in particular just want good news. So if you're a primary care doctor or you're a non-surgical person and you run into someone who has a situation that you would describe as pathologic, oftentimes you don't want to say, you have something horrible and you might die. The reason you don't do that is because whether it's true or not true, it makes you uncomfortable, it makes them uncomfortable, and now everybody's uncomfortable, and it's a very bad situation. So what you would rather do is say something a little bit less dramatic. Now, I'm being funny for the purposes of calming everybody down for the topic, but here are the facts. Right now, the Society for Thoracic Surgery and the Society for Vascular Surgery agree that any aorta that measures 4.0 centimeters or larger is considered an aneurysm, and anything greater than 4.5 centimeters is considered a large aneurysm. And when you get into the 5 centimeter range, conversations about surgery should start. The reason I lay that out very simply for you is so that you can have numbers in your mind and understand that closer to 4 oftentimes is a little bit larger than we like it to be, but it may not become a big problem resulting in the need for surgery. But it getting near 5 centimeters, that really should prompt a discussion. And one point I'd like to make is that if you are following with your primary care doctor or a cardiologist or someone who doesn't operate on the aorta, please refer yourself to somebody like me, not because we're going to automatically operate, because I promise you we will not, but because you really want to know the truth before you get yourself all freaked out, stressed out, and a complete mess about something that may not actually ever come to anything major. Okay?
Okay. We have a question real quick. So Chloe wants to know, is 38 too young to have this type of surgery, or a surgery to correct an aneurysm? And if so, what would be the age range? Or does that even play a part?
Chloe, unfortunately, that has no role in this. Age, unfortunately, is just age. And as most people want to talk about age, we don't talk about it at all. We only talk about the aorta, and we talk about your family history. So let me go explain a very simple concept here, which is that people can have aortic aneurysms that are non-pathologic, and people can have aortas that are not aneurysmal that can become pathologic. Let me go back. If you have an aorta, you potentially could have a problem. And if your family members have had problems with their aorta, there's more likely chance that you will have the problem and need to get checked out and followed. So, what does age have to do with this? Absolutely nothing. But if you have an aneurysm defined as greater than 4 centimeters at the age of 38, you will likely need an operation at some point in your lifetime simply because we want to get you to 80 and change. And that's a long time to live with an aorta that's already large. Why am I saying this? Because my experience and our collective experience with the aortic surgeons is that it will grow about a millimeter every year on average over the course of time. It usually grows a touch faster as it's getting bigger, but that may be just a relative percentage mathematical equation and not anything surprising. But age has no role. If your aorta is big, you need an operation. If it's small, you don't need an operation unless you have a very, very, very strong family history of aortic dissection and rupture at normal sizes, in which case a conversation with a surgeon is really important.
And let me ask you, let's go back a step. What would be the ways in which aneurysms are discovered? What would be the appropriate test? Because we know they show up sometimes second to something else that's being looked at or looked for. So what are
Correct.
typically the tests or the best test? If you know you have family history, what would be the best test to have?
So most aortic aneurysms are picked up incidentally because somebody comes in with a cough, a cold, a flu, a car accident. As you can all imagine, since the spring of 2020 till now, CAT scans of the chest for patients who come in with COVID symptoms led to an unbelievable discovery in our hospital, which was that we found aortic aneurysms in multiple patients up to the tune of 5 and 10% of the population, which was much more common than we anticipated and expected. But in Brooklyn, we have a heterogeneous population of people, meaning we have people from all over the world who share all different kinds of genes. And therefore, we don't have just one genetic line. And this is actually probably showing us a reflection of what the incidence of aortic aneurysm is around the world. Now, going back to your question, if you are going to get a standard workup and you have no family history, right around age 50, you're going to wind up with an echocardiogram of your heart, which is going to also show the short portion of the ascending aorta. And you're going to get an ultrasound of your belly, and that's going to show your aorta in your belly. But that only gives you visualization of about half to 60% of the aorta. The part that you can't see is the part in the arch or the top of the candy cane and the stuff going down the back. Now, if you have a history of aortic aneurysm rupture or dissection or unexplained sudden death in your family, you need a CAT scan about 10 years prior to the event of that relative, such that you can get evaluated and somebody can look to see if your aorta looks funny. Funny could be a funny shape, funny could be large, funny could be thin, it could be narrowed. All kinds of things get picked up sometimes with CAT scans. But for complete evaluation of the aorta, you need a CAT scan or an MRI. Both of them will show it to you. So one is not necessarily better than the other. Our standard of care has become a CAT scan. This may change. Right now, the standard of care still is a CAT scan.
So one of the things you said was it's more common than you think. And I know we talk about this a lot. However, when a lot of people look up aortic dissections, aortic aneurysms, they're hit with this word of rare, or it typically happens to a male, a white male over the age of 60, 65, obese, smoker. And as we've come to learn, those of us in the community, this is not accurate. This description is not necessarily true for all of us that are sitting here that are not 65-year-old men that are overweight and smokers. So can you talk about that a little bit more and get into a little bit more about how this is a lot more common than we think?
Okay, so you want me to address the misinformation on the internet just in a brief few
Yes.
moments? Is that what you're asking me, Karen?
I know that's really difficult. But I mean, why is it coming up and saying it's so rare? Why? I mean, we can't explain why this information is so outdated and inaccurate. But why is it saying that it's rare? Why is that we feel like we're part of this rare group?
Yeah, so I'm going to have to bring this back to when I was in medical school in the 90s. We learned some very basic things about aortic aneurysm and aortic dissection. And those basic things are completely wrong now because we've progressed. In 1999, we sequenced the human genome. In the subsequent years, as we took people's aortas and their blood tests, and we took little pieces of the tissue inside their cheek and we checked it, we found all sorts of genes associated with heart disease, stroke, diabetes, cancer, and aortic disease. These big five things are associated with genes that prior to the sequencing of the human genome, we only had a small inkling that it was likely, but we didn't have any data. Now we've got a treasure trove of data. So we've gone from a modest amount of data coming out of the 60s and 70s and 80s. We are now swamped and overwhelmed. So, what is easy to bubble to the surface? The basic, simple messages from the 80s, which have now become obsolete, but they were pushed up to the internet in the late 80s and 90s when the internet was started, and all the textbooks and all the papers and all the things that we all learned are sitting there. There's absolutely nothing I can do to reverse this except being part of an organization like Think Aorta and working with you and pushing up information to the internet and exposing all of the people that we can reach to the reality, which is that as of now, we are in double digits of the number of genes associated with aortic aneurysm, rupture, and dissection. We are very, very clear that it is not associated with atherosclerotic disease or hardening of the arteries in the overwhelming majority of cases. We are very clear that men are affected twice as often as women, but that women stay at home and don't come to the hospital because they're so much stronger willed and so much more stoic about pain than men are. And so oftentimes women will die from the disease more likely than men. We also know, because of studies in Japan where autopsies on people were performed, that the number of patients who die at home from aortic dissection because blood rushes in around the heart and squeezes the heart and they die from that is far more than anything we could have possibly imagined. And again, in a study that we performed in Brooklyn during the COVID months in 2020, we had an incidence of aortic aneurysm that was 5 and 10 times anything that's ever been reported. And all of these things are not random. They are the true facts of aortic disease. And that's what we got to do. That's why we're here. We got to push this information out there. And hopefully everybody will start to understand the real problem, the breadth of the problem, and they will start to pay attention that these things run in families and we can really keep people from getting hurt and from dying from this problem.
So what would be the things you'd want to listen to and pay attention to or ask of your family members, other than obviously if somebody's had a dissection or a known aneurysm in their aorta? I don't think people realize that an aneurysm in the brain would be something that would be on that list. But what would be some other medical conditions that if you knew your grandfather or maybe even an aunt, possibly that they had this that you should be talking to your doctor about looking into getting a baseline test?
Clearly, anybody who has the word aneurysm associated with their condition needs to be a red flag that goes up. Now, an aneurysm of the aorta versus an aneurysm of a branch of the aorta is not a dissimilar condition. We do see an association between aneurysms in the brain, and there are aneurysms in other portions of the body also. That association seems to be roughly 10 to 15% backwards and forwards, meaning if you have an aortic aneurysm in your chest or belly, there's a 10 to 15% chance you could have one in your brain. If you have one in your brain, there's a 10 to 15% you could have one in your chest and belly, meaning cerebral aneurysm versus aneurysms in the chest. Now, those are the two most common aneurysms that occur, but they do occur in other branches because the condition is related to the vascular system. It's not related to the aorta, which is just a piece of the vascular system. The best comparison I have is if you have a condition of the skin, it's the skin. It doesn't matter if it's the skin on your hand or the skin on your belly or the skin on your neck. It's still skin.
Right. Right. And we've talked about that. We've had somebody in the community, as well as if you watch certain reality TV shows, a woman who had a SCAD, which was that's a spontaneous coronary artery dissection.
Correct.
And so, the question was, if you had that in that isolated area of your coronary artery, are you at risk for having issues in your aorta? And obviously the answer is, of course. Like, using the example of skin makes so much sense because it is just the vascular system in itself. So therefore you should be scanned anywhere. So that's another one. I wrote that down, skin. Like, when we're going to talk about in a minute, let's get into dissections. I love how you describe your paper towel roll.
Everybody's done this. Like, we've all, tried to, you're using the last paper towel, your hands are dirty, you take off the last thing, the paper towel roll, it's kind of the tube swirls around the counter and falls into the sink, and you go, oh, shoot. And then when you pick it up and you look through the middle of the tube, one of the layers is peeled off. And instead of seeing one circle, you see two circles. And when you see that second circle, that is exactly what it looks like in the aorta when I cut across an area of dissection, and you've got blood going in the area, what we call the true lumen, and then an area of what we call the false lumen. The false lumen has an area on the wall that has fewer layers than it had before the dissection. Of course, that area is weak. And if it doesn't rupture right then, over time, that area can increase in size. And that's why after these events, you have to be on blood pressure medication, control your heart rate and blood pressure very, very well. And I don't want to bring up any math because it's late and I'm sure it's going to make everybody very upset. But calculus, and Sir Isaac Newton, who invented calculus or who figured out the concept of calculus, it's very easy to understand. And the best example always is if a bird is flying and you think about the effort it takes for the wing to go from the top to the bottom, pushing against the air, you can understand, if you've ever lifted weights, that there is a different effort at the top and at the bottom. Same is true for the aorta. And what you want to do is decrease the force inside so it decreases the movement, and the movement causes stretching, and stretching can cause injuries, and injuries can cause problems, or injuries can lead to increase in the size, which of course we know is directly related to the risk of rupture. And that's true for an aneurysm, and it's true for a patient who has an aneurysmal dilation of a dissection, which is healed or healing. These are important distinctions. They are different words and different conditions. And please don't worry that you get it wrong, because many or often I deal with physicians that get it wrong.
And so, okay, looks like we have a question.
Excellent.
So Chloe says that I guess she's already had emergency surgery, and after surgery How does life change for those who have had emergency surgery?
I don't know if I am the person that should be answering that question, Karen. I sort of think that maybe it should be you, don't you think?
Well, yeah. I think maybe what she's referring to is restrictions, which, as we always mention these conversations, these are talking points for individuals to take back to their own personal physicians. And this will move us into the next conversation about exercise. We often talk in the community about what our new normal looks like coming out of
Right.
an emergency event.
Right.
And gosh, do we hate those words, because all we want is just to have our life back. Well, you do have your life. It might look a little different, but things happen. And so maybe you need to have a little bit of restriction in one area, but you might become even better in another area. I look at it as, if people lose their sight, or they lose their ability to hear, if it's become diminished, other senses tend to become more heightened. So just because somebody can't do work in a certain area doesn't mean now they can't flourish in another area. So your life will probably change depending upon whatever restrictions were given to you or guidelines that you should follow. But look, your life, you're 38, your life is your life to make of it. You're going to have now, 2.0 version, right? So make it whatever you want it to be. You might even have a 3.0 at some point in time. I wake up tomorrow and be like, it's 4.0 for me. Look, January started. I had that Coca-Cola. I said 2022 is already over. I'll shoot to do better in 23. So you never know. But from the community standpoint, that's part of what we help people work through in Aortic Hope, is just to meet you wherever you are, because it does change like the tides. Some days are really great, some moments are really bad, and then the next hour they're really great. But I think if she's maybe she's referring to typical restrictions or change of life for a patient that a physician would put in place. You muted yourself accidentally. Don't do that.
You did it to me on purpose. I know you.
Probably.
So, Chloe, listen, there was a patient that had a type A dissection a little while ago. And last week I was walking in the hallway and I walked up to him and I said, congratulations. This is fantastic. You're alive and you're doing great. And I'm really proud of you. And this is not easy. And connect with people. And of course, I gave them, Karen's home telephone number, and they know about, Aortic Hope and Aortic Bridge, and they know about all this sort of stuff. But that's number one. Congratulations! Like, this is awesome. Like, you lived, you're through this. This is awesome. This is the biggest hurdle ever. I mean, the Olympics are on. This is a marathon, big time. The second thing is, be nice to yourself. There are some people that Karen and I know who are not nice to themselves. And I got to tell you, Karen Anderson is very nice to herself, and she should be, because the truth is that one of the most difficult things that we don't do as Americans is we don't take time to, all you can use whatever analogy, smell the roses, drink the coffee. Well, we drink coffee, but, do all of those things that we just take a little bit time to do. Just be kind to yourself, especially at first. Then when the dust settles, which it takes a long time to settle, we're going to talk about the basics. Everybody jokes, everybody laughs at me when I say this, but once you've healed up and it's been a couple of months and you've followed up with your surgeon and you've had your repeat CAT scan and everybody's comfortable with where you're at, here are the basics. No contact sports outside of the bedroom. I need you to do exercise for an hour a day of some sort, because it's going to make your life better. And you shouldn't lift anything heavier than about 100 pounds. Let me talk about the 100 pounds real quick. We are not going to go back to the other comments. 100 pounds came from, how much should we tell people to lift? And we started saying half of people's body weights, because if you think about half of your body weight when you were at, well, you're 38, so you're probably pretty close to your fighting weight. Half of my body weight when I was at my fighting weight was about 100 pounds. So I'm 6'3", 200 pounds, that's about 100 pounds. When I was smaller, or when there's smaller people, is less weight. But the truth is that the average person, when straining themselves, if they really wanted to, probably could lift about 100 pounds. And the reality is that I don't want you to do that, but there are going to be times in your life when there's something that has to happen. And I just refer people back to the basics. Don't be the bodybuilder lying on a bench press machine trying to take a deep breath and strain themselves and push as much weight as possible. If anything's too big to carry, you don't want to deal with it, hire somebody to do it or ask someone to help you. But all the while, when you think back through what 100 pounds is, 100 pounds is, two of those massive dog food bags. Nobody carries that. 70 pounds is one of those bags that they yell at you when you try and, put onto the plane. 100 pounds is a lot of weight. So, restricting you to 100 pounds is probably just fine. But the key is you don't strain yourself. You don't put yourself in these, crazy situations. You don't do crazy bench pressing, crazy squats. Just get some normal exercise like a regular person and live your life. Go see your surgeon, go see your cardiologist and your primary care doc, take your medications and live your life. Let the doctors worry about your stuff and live your life. Before this or after this, you don't know what's going to cause you trouble, but you just have to follow rules that make sense. And so that's what I tell everybody.
So I'm of the belief that if I'm about to do something new or take a new medication that another doctor's prescribed, I like to double check. I like to always make sure with my surgeon or definitely with my cardiologist that it's okay. So I have learned that scuba diving is a no-no. And maybe you can explain why scuba diving is a no-no.
Well, so probably the number one concern that most people have with respect to scuba diving has to do with two separate issues. One is that if you're scuba diving and you have a problem, you're not exactly in the most easy to fix location, situation, 30 to 100 feet underwater, out on a boat in the middle of nowhere, putting your body under certain strain. It's not exactly the most perfect situation if you were to have a problem.
Right.
So that's number one. Number two, when you are scuba diving, and I have done my fair share of scuba diving in the past, there are some pressure changes that certainly can affect your blood pressure in different places. You could be head up, head down, moving around, all kinds of stuff. But the largest concern that I actually have has nothing to do with the scuba diving itself. It actually has to do with the fact that there are situations where you're on a dive boat and it's 100 degrees and you've got a big wetsuit on, or or it's 50 degrees and you put on a wetsuit, and now you're putting on 50 pounds of weight. Now you're putting on lead weight. And remember that 100 pounds we talked about? Well, you're kind of creeping up on it. And now you're straining yourself to walk around on the deck, and now you're straining yourself to get off. Then you're straining yourself to get back on. Water's choppy. You get hit by the swim deck. All kinds of weird stuff can happen. So here's the way I would approach it. And one of the guys I used to do a lot of scuba diving with back in college used to say that he loved doing just snorkeling, because the truth is that you can go out, you can be out there much longer, you can enjoy yourself without all the back discomfort, you can swim around, you can see most of the fish, and quite frankly, you don't get as cold, you don't get as miserable, you can get in, you can get out, you see a bunch of cool stuff. And in truth, you're not missing that much. Now, where could you be missing stuff? Well, that would be if you're doing full penetration diving in a submarine or in a sunken ship or in a cave. Hey, listen, that's a little bit dangerous stuff to be doing if you've got a condition anyway. So I don't know why any individual physician says don't scuba dive, but that's sort of my list of things.
And then the only other thing that I've heard asked, and I've called you from Disney.
You're not going to talk about the roller coasters, are you, Karen? Please don't.
Rides. I called you and I said, can I do Tower of Terror? And I was standing there staring at it. And you said, if it's going to get you too amped up and your adrenaline's going to surge, then you probably shouldn't do it. And I looked at it and I turned around and I went and did something else. That's okay.
I mean, the G-forces on these rides certainly can change your blood pressure. You're holding your breath, you're screaming, right. Especially you, Karen.
Oh, please. Yes.
So I mean, listen, we're you know, Chloe, you're 38, you're a kid, right? But we're not kids anymore. And I would love to say you can go on a coaster or do whatever you want, but like, you know, at some point we all have to say, yeah, you know, I don't need to go on that. You know, everything in moderation.
I hear you. We have another question. Our Terry from the board of Aortic Hope. She's the first person in her family to have not only a type B, which is what she started off with, and then 10 years later, she had a type A dissection. So she has a son. And the question is how important would it be, since she's the first that she knows of? I know we'll say that for her son to be scanned, and at what age? I'm going to throw that in for good measure. And she can't wait to meet you.
Oh, that's very sweet. So, okay, so let's go back to the, we haven't talked about the names yet.
Types. Yes.
So as I tell all the medical students, stop laughing because you know what I'm going to say.
Say.
The type A is in the ascending. The type B is in the B-sending. I know it's stupid, but everybody remembers.
Yeah.
So the B is in the part that goes down. The A is in the part that goes up, top of the candy cane. The aortic arch, which is at the top, that actually is a subject for a lot of discussion, even amongst radiologists and heart surgeons. And so we have to have a conversation about it. But largely, the names have to do with being able to communicate really well in an emergency very quickly about where the patient needs to go. Do they need to go to another hospital? Do they need to go to the operating room? Do they need to go to the intensive care unit? Where do they need to go? There is a brand new naming system that we are just coming out with. And you can see from my face that I am moderately interested in it. And it really is great for surgeons to have a conversation about this. But I will tell you, in my practice in Brooklyn, the overwhelming majority of the people that I will be speaking to have no idea even what the patient has, let alone I'm not always sure when I'm dealing with people in training or it's the middle of the night and things of this nature. I'm not even sure if I have a aneurysm, a dissection, a type A or a type B. And I certainly am not going to be talking to that many people who are going to know this new system. Be that as it may, dissections or tears in the aorta can occur anywhere. They can occur anytime. And yes, I have a series of patients. You are unfortunately one patient, but there are a lot of patients out there that will have a dissection in the descending aorta or even in the belly, and then have another one in a different area, or they will have an extension backwards or forwards of the dissection that will then result possibly even in an emergency operation. It's not uncommon. So what you're saying is actually right. You had a type B, it had some degree of stability, then you had a type A that then needed to be operated on. Okay. In terms of what you do with what we call the first degree relatives, siblings, parents, and children. When someone has a dissection or diagnosed with an aneurysm, all of the siblings and the parents, so everybody your generation and older, need to get evaluated immediately. Immediately. The younger ones, we evaluate 10 years before the event, whatever the event is. If the event is the discovery of an aortic aneurysm, it's 10 years prior to that. If the event is a dissection, it's 10 years prior to that. So it would be 10 years prior to your type B dissection, telling your son's physicians and to carry it forward in the medical record that you had an aortic dissection and whatever other relatives did, and to make sure as time goes on that consultation with a surgeon, because we are getting more and more and more information as time goes on, but not everybody is getting more information. So definitely stay in touch with us, which of course you will be, but your kid, boys are different, as we all know. Boys, get doctors when they have a problem. Girls are a lot smarter. They tend to get doctors all the time. So you got to keep an eye on the boys.
Let's talk a little bit. Oh, I'm sorry. Before I tell you my question, I've been writing little notes. We have a question. So David has a question regarding what happens when you have a type B repair. He presently has a aneurysm of 5.7 and was told that he's going to need to have that repaired. So what happens? What are the options?
So, David, obviously, I don't know what the anatomy looks like for your type B dissection, but generically speaking, the type B dissection will occur around the artery that goes to the left arm, which is usually, but not always, the last blood vessel comes off the aortic arch. Occasionally, the last blood vessel that comes off the aortic arch can be the actual blood vessel that goes to the right arm. Sometimes the blood vessel that goes to the brain is actually sitting right there. So it's extremely important that you hear what I'm saying, which is that the repair is directly related to the anatomy that you have in particular. Now, in our practice at the Aortic Center, myself and Dr. Ree, we work very, very hard to do all of these cases with a minimally invasive approach. And the reason we do this is because aortic dissections, despite everybody's dream, they are the gifts that keep on giving. And we like very much to say we're going to repair them and then they'll go away. But whether we do the surgery with a big incision in the back, or we do the surgery with an endovascular approach and maybe some rearranging of the vessels to the brain, there's usually going to be another operation that's going to come down the pike after that. Not always, but oftentimes they are. And so Dr. Ree and I, we tried very hard to do these with an endovascular approach. We look at these patients in our aortic conference and we have conversations about this. But the two ways we can usually do this is with an endovascular stent graft, usually placed through the groin, often but not always done with some degree of surgery in the neck. The second option is an open operation with a large incision in the back. And the purpose of doing one or the other is to obliterate the area of weakness from the pressure of the flow of blood. And your individual case, I would have no way, of course, from the question to figure out which is which. But I will tell you that in aortic centers and progressive aortic centers, we are trying very hard to do these operations with the least amount of open surgery in the initial phase, if possible, and try to jump in early so that the aorta doesn't get so big that we are actually forced to do a big open operation, which sometimes happens anyway. But fundamentally, our goals, at least at Maimonides, is to try to do this with the smaller incision with the least amount as the time goes on. And this is something else you should know. We do a lot of staged operations because when we started doing these stent grafts in 2005, we had a risk of paralyzing patients in the 5 to 10% range because our fundamental understanding about how the body was going to react to these stent grafts was very rudimentary. And as we learned how to do things better and we learned how to take care of patients, we realized early on that we had to make some changes. And we've been making a lot of changes. And sometimes when people have type B dissections, we will actually do 2 or 3 operations separated out by 3, 6, or 9 months in order to decrease the risk of paralysis because of coverage of the little tiny blood vessels that go to the spinal cord. So I know that's an unbelievable lot of information, highly technical stuff, but the simple answer is there's open operations with an incision, there's endovascular incisions, and every single case has to be tailored to your particular aorta and I can only say that when people come to me and they have questions, I always send them for a second opinion because I really want them. I want them to believe that what I'm telling them is right. And I want them to feel absolutely confident and comfortable with their surgeon without any reservation because it's a challenging field. Operations are very complex, and future operations can become more complex or less complex depending on how the body reacts. So the best thing you can do is become an informed consumer, but that does not necessarily mean that you should sit on the internet until 3 in the morning. Please seek out people who work in an aortic center, who have a good relationship with their cardiac and vascular surgeons, so that you feel like you're getting a lot of input from a lot of smart people, as opposed to just one person who says, this is what I do, or this is what I've always done. Those people always make me nervous, no matter whether I'm, doing it. The only place that doesn't make me nervous is in a restaurant. That I like. That's probably the right place to say I do what I've always done. But
now, what you're describing is TVAR, because we've heard that terminology. So that's a thoracic endovascular repair.
Aortic repair, yeah. TVAR.
So TEVAR. Okay. Then there's also a TAVAR, right? That's different.
So, right, a transcatheter aortic stent graft versus a transcatheter aortic valve.
Okay.
And unfortunately, they keep changing the terminology. That's why I stick to the terms: a stent graft, TVAR, thoracic endovascular aortic repair, minimally invasive repairs. I try to use the words that are very clear, as opposed to sometimes it gets confusing.
Right. Okay. Let me check and see if we have another question. About, we have a question about sodium. So Tom would like to know your thoughts about sodium intake and diet post-dissection.
Salt is one of the greatest gifts that has ever been placed on the earth for us to eat our food with, Tom. I don't know any other way to say it. When all of us get older and we are all looking at how to eat our food and how to approach food and how to figure these things out, the answer always is everything in moderation, right? Sugar in moderation, salt in moderation, fats in moderation, yada, yada, yada. But the basics really are, if you decrease your intake of prepared foods and you increase the food that you're making at home and you save the placement of the most beautiful thing in the world, the salt, with those big, yummy pink crystals and black crystals and stuff, and you put them on your food afterwards, I have found that it's much better and you use a lot less salt. There are some really smart people, and I was actually on a radio show not that long ago with a crazy smart hypertensive physician, and she was talking about the management of hypertension with potassium chloride as opposed to sodium chloride. And she taught me and my partner something pretty amazing, which is that routine use of potassium chloride actually decreases your blood pressure by 5 or 10 points. Now, I'm not saying you should go and do that, and you should definitely talk to your physician about it. But the idea is that there are so many new and exciting things out there with regards to diet and high blood pressure management. The key for you is find physicians that you trust and you can work with, and try to just follow some basic things, which is that salt and hypertension are related, but that you can avoid a lot of salt by, avoiding all those prepared foods and having all those prepared meats less often. And that's probably the best thing you can do.
I never thought about adding salt after versus when you're cooking. That's interesting. Adding it after. You do probably use a lot less. Thank you. Thanks, Tom. Let me see if there's any other questions real quick. Peter from New Zealand. Thanks for tuning in, Peter. Peter's question is, has COVID had any major effects, I guess, within this community?
Yeah, so Peter, thank you so much for tuning in. I guess it's like, let's see, it's 7:50 here, so it's like 36 hours minus 24 plus 2. I always forget the math in New Zealand. But the real issue that COVID has done is it's caused avoidance behavior by a lot of patients to not get their routine follow-ups, to not go see their physicians, and not get their blood pressure checked, and not take their medication, and not go into the hospital. And it is absolutely and completely understandable. If you weren't somebody like me that goes in the hospital every day, you probably would be right to avoid the hospital. But the problem has been for us is that I've had multiple patients who've had problems, and patients who've come in with aortas that made me very uncomfortable because they missed a year or they missed a 6-month checkup when they were close to needing surgery. And so the number one effect that COVID has had really is the avoidance of people caring for themselves and all of those associated problems. And you can just imagine in New York in the spring and summer of 2020, how many disasters occurred because people were having heart attacks and strokes and probably aortic dissections and abdominal pains and on and on. And they said, I'm just going to stay home because, we were overwhelmed. They were overwhelmed. Everybody was overwhelmed. And it's very sad what occurred. That's probably the number one issue. On the other side of the street, it allowed us to perform this study where we looked at these over 1,500 CAT scans because there were so many patients early in 2020 being diagnosed with COVID with a CAT scan. And it allowed me to look at their aorta and call them up and talk to their families and get them into the system and tied in and get them to realize that, hey, this is amazing, but the numbers were much higher than expected. But I would like to believe that we created an opportunity to save a lot of lives, but really the benefit will be when we get this paper published and we can all go and refer back to it and people can do the studies in their own town. So I think, there've been some good things that came out of COVID. Obviously, 1 million dead people in the United States and others all over the world is overwhelming. But there have been a couple of good things, and I hope the good things stay. And obviously, I hope this virus sort of drifts away, but we'll have to see.
Now, one of the things, what can you discuss? Because obviously the virus doesn't discriminate. It doesn't know that somebody has a compromised aorta, but somebody who does get COVID, who has an aneurysm or has had a dissection, what are some of the things that COVID actually is doing to the body that could affect us a little bit? It makes things a little bit more precarious for us with heart rate or blood pressure or anything like that.
Anybody who's having any sort of concomitant illness on top of any, sort of major, issue situation that they're dealing with, it complicates everything. But I told you many times, and I tell everybody, reassure you, these are two totally separate systems. If something terrible happens to you, then something terrible happens to you. But the two systems don't necessarily interact directly in a way where I can tell you, because of this is going to happen. They're really very much separate.
Okay. All right. Let's check and see if we have any other questions. Okay. Chloe has two-part question. When you have an aneurysm, is it common to encounter another one or have another one grow in another area? And her second part is high blood pressure typically expected in these situations?
So high blood pressure is extremely common in patients with aortic aneurysm, rupture, and dissection. We don't really know why, but it's absolutely present in at least 75% of the patients that we see who come into us with this condition. Now, I'm a heart surgeon. Somebody gets a CAT scan, they get diagnosed and told they have this thing. They jump on the internet, they start reading, and then they come into me. What a shocker that they have high blood pressure. So I'm not really sure if that is true and related or true and unrelated. But what I definitely know is there's no question about it that anybody diagnosed with an aortic aneurysm or aortic dissection has high blood pressure in the overwhelming majority of the cases. And this may very well be related to something that many of you have participated in, which is our study that as out of Maimonides, which has been on the stress associated with just the diagnosis of aortic disease in your family. Next step being diagnosis of aortic disease in yourself, followed by a type B dissection, followed by aortic surgery, and then the big one, type A dissection and surgery, which has a incidence of post-operative post-traumatic stress disorder such that you're having trouble living your life of almost 50%. That condition is definitely associated with an increase in blood pressure. And so you have a self-reinforcing phenomenon of high blood pressure that you may have had. Now you've got this wallop with this condition, which now you've got the stress of that on your life, which then increases your blood pressure. So it's a problem. But whether you take one medication or two medication or three medications, just take the medication. The only thing that can come up, which everybody on this call who's on them knows, you can get fatigued, you can get lightheaded at times, you can have trouble going from a standing to a sitting position. And for men, we should mention that erectile dysfunction is a real condition that we have great treatments for. I know you've probably never seen a commercial on television about erectile dysfunction, especially when you happen to be watching a cartoon with your young child and you see this commercial and you immediately distract them with anything. No, I'm kidding. Listen, erectile dysfunction is very, very real, and it really needs to be talked about. And people get very uncomfortable talking about erectile dysfunction and sex, but we really need to speak about it because it's a big problem. It can be addressed. Please don't address it by not taking your blood pressure medication. You can go see a urologist. They can make sure that there's no issues. We can then deal with it with Viagra or Cialis or one of the other medications that are on the market, please. That's question number two. I'm going to go back to question number one. Aneurysms are an enlargement of the aorta in any location, and they can occur in multiple locations. They can occur in your brain in addition to your aorta. They can occur in all the blood vessels. It can occur anywhere all the time. Once you have a dissection, that tear is usually from the location where it started downstream, and that is usually called a dissection, but then you can get an aneurysm of the dissection. It's very technical terms, but the simple answer is yes, you can have an enlargement in multiple places, or you can have an enlargement that goes all the way down through the whole thing. It's just, what you get, what genes you got, and how it expresses itself in your body.
You just said a good word that just prompted me before we take any other questions, genes. So one of the things we talked about is having your immediate first relatives just go get a test. Just go get a test if something's happened in your family. A lot of people run right away to go get genetic testing. It's become ingrained. Let's just go get genetic testing. And I know there's a lot of different ways of looking at this. And I know for myself, I was one of those people. I wanted to go get tested. And then I really quickly realized, well, even if they found something in me, it's nothing I can do about it. There's nothing, no pill I can take that makes it go away. I would just be monitored. I'm already monitored because I had detached retinas. I'm already monitored because I've already had a dissection and aneurysms, and so did my father. So I'm going to get monitored regardless if I had some type of genetic issue. Let's talk a little bit about genetic testing and why, and what would be the scenario in which you would personally say someone should be tested.
Okay, spoiler alert, Karen, you have a genetic problem.
I just don't know what it is.
Right, you don't know what it is, and neither does anybody else.
Right.
So you are the perfect example of my whole point of this, which is in 99, we sequenced the human genome. 23 years later, we've got a lot of genes, but we don't have them all, and we don't know how these genes work, and we don't know how it interacts, and we really probably have just scratching the surface on this stuff. But there's no question in our minds that if you add up all the people in the family, in all these different families, that it runs in the family. So there's no question. So if you've got the condition, getting genetic tested will do, maybe ease your mind, maybe make you happy, maybe make you sad, but it's not going to change anything for you. It's not going to change your treatment usually at all, especially for an adult. There are occasional conditions for children who can get these conditions where things may occur. But if a child gets a dissection, they're already in an exquisitely complicated situation, and they're already going to be going down that pathway. So what I'm alluding to is the fact that the pathway that you wind up on is going to be the right one, provided you find the right surgeons and find the right group of physicians to deal with, irrespective of the genetic test results, because right now we don't have all the information. Now, if you want to be a good steward of this information and of your condition, by all means contribute to all of the genetic research that's going on around the world. I know for myself, I am doing it because there's a lot of cancers in my family. So I'm involved in some genetic work. But the truth is that it's more an altruistic approach, because it's probably not going to help you or change your treatment. Okay, but what about your children? So if you get diagnosed with a genetic condition and your children of childbearing age get diagnosed with the condition, but they don't have any signs of it because their aortas look totally normal, well, the question begs, what are they going to do about it? Well, I'll tell you one thing they're not going to do is, if you get them genetic tested and if they wind up trying to get disability insurance or life insurance, they may have a challenge getting that. Because if you don't disclose certain things on your disability and life insurance, and then you try to cash in and they go back and find out you had genetic testing and the genetic testing led to that condition, they're not going to pay. They're private companies. They can do whatever they want. Your health care cannot be kept from you, but your other insurances can.
Mm-hmm.
Now, the reason I point that out is because it's something that people don't talk about, again, like some of those other things we don't talk about. And for the most part, I myself approach my patients in this way. I say, I'm happy to get you tested. Here are what I view as the risks and benefits for you, and here are the risks and benefits for the rest of your family. And if those are fine with you, let's get you to a genetic counselor who will reinforce this, and then you get tested and we'll figure out what to do with the information once we get it. But I promise you, I will not treat you any differently, irrespective of what I find, because the overwhelming majority of my patients, the youngest ones being in the 20-year-old range, usually have all the conditions that I would expect to see from someone who has a connective tissue disorder often already. They've got multiple injuries, they've got knee arthroscopic surgery, they've got problems with their vision, they've got a blown Achilles heel, on and on and on, all kinds of weird stuff. So those are the two big things that come up with genetic discussions. And I'm saying, by all means, contribute to the fund of knowledge and the medical community and all the information, because it might one day help somebody. But I believe very strongly that over the next 20 to 50 years, we are going to learn so much more and get so much closer to having a clue. But between now and then, I'm looking at retirement, maybe some trips to the Caribbean, and I'm not going to treat my patients any differently with the information that I have today as of 2022, even with the genetic test.
Right. Okay. Let's check and see if we have a couple more questions before we wrap this up so you can eat dinner. Sure. Okay. Lori had, I guess, the pleasure of meeting you. Dr. Asterian was her surgeon at the time.
Dr. Asterian was one of my former partners. Good guy.
Okay. Yeah, so Lori had mentioned that she had genetic testing and had nothing, and yet two other family members, father and grandfather, both had aortic issues. And that speaks again to, what would you say the percentage of people that have aortic disease that have not had a gene identified?
As of now, I don't have that number. That's a tough
Okay.
number to come around. But here's what I do know. If you add up what I learned in medical school and all of the known syndromes, Ehlers-Danlos, Loeys-Dietz, bicuspid aortic valve syndrome, Turner syndrome, Marfan syndrome, all of those taken together make up less than 10% of all of the patients that I see with aortic aneurysm rupture and dissection, leaving 90% of the patients that don't have any of those syndromes. Now, in terms of the other genes that are out there, I can't tell you the percentages because I don't think we're there yet. I think that there's some numbers out there that I'm not going to quote, but we're not there yet because we haven't had a big enough sample. But if you think about just what I said, which is just from the 90s till now, the knowledge and understanding about aortic aneurysm rupture and dissection has changed so dramatically, so dramatically. But Lori, thank you for the call. I'm glad you're doing well. I hope you're going back and seeing Dr. Asgharian. If you're not, make sure you see somebody. If you want to come to Brooklyn, come over a couple bridges, you come see me.
Okay, we have another question. "35-year-old woman after dissection repair, sitting at 4.7. Is that considered too large after repair?"
Yeah, so obviously there's so much information that I would need to answer the question, but let's talk about numbers a little bit. Preoperatively, following patients in the office, if they have a very strong family history, I put them in the high risk pool, patients with multiple other family members, or they're one of the syndromic patients. I would operate on them at 5 centimeters in the ascending aorta, 5 or 5.5 in the arch, depending on how complicated the operation was, usually 5 centimeters or 5.5 in the descending aorta into the belly. And those numbers, like I said, around 5, all have to do with a primary surgery. If you take someone who then has surgery, things change. Usually, if you're talking about an operation in the area of surgery, we increase the indications for surgery by about 1 to about half to 1 centimeter, or we subtract a half a centimeter from what the indications would be if you didn't have this condition. Okay, I'm going to try and clarify that because it's a little confusing. So you've had surgery. Your aorta, if it was not a dissection, you would have been operated on at 5.5 centimeters if you had no family history. And if you had a redo, you would have been operated at 6.5 centimeters. Depending on the condition and where the problem is now, you might get operated on at 6 centimeters, or maybe you can have an endovascular operation, which we might drop to 5.5 or even 5 centimeters, depending on the location. The information I need to answer your question basically about the size is so complicated because all we do is we take the risks of the surgery and we compare it to the benefits. And if the risks of surgery are a little bit elevated because in order to accomplish a successful operation, we have to do more stuff. Each of those things we have to do increases the risk. We may add the size to the indications to push back the surgery a little farther as we balance the risk and benefits. That's what we do every day with every patient all the time. So there's no way for me to give you a number except to say that walking through this conversation with your surgeon is so critical for you to really leave their office and with a clear understanding of where you're at, because it affects everything you do.
And as another patient, I couldn't agree with you more. There's nothing more frustrating than going into your doctor's office and just being told, this is what we're going to do. This is the plan, and that's it. For me personally, I like to have a better understanding of the why, the when, the how. I like to have all of that in case I come up with more questions, or it helps me better prepare for if and when that day comes. If I have a clear expectation of the plan, then it enables me to live my life with a little bit less stress because I already know what's going to happen, and versus just being told it's happening, or being told I'll call you when it's time. That's not enough for me either. I want to understand, why are we waiting? What are we waiting for? What can I do to put myself in the best position to maybe avoid that? How can I best control what's going on in my world, whether that's my blood pressure, what I'm eating, exercise, stress, all of that. What can I do to prepare myself or try to help stop something? And there's only so much that's in our control. So that's a good question. Two more questions before we go. Okay. So first question, do aortic aneurysms always grow? Will they always eventually grow?
I wish I could answer this with the answer that everybody wants, but the simple answer is that the overwhelming majority of aortic aneurysms and aneurysms of aortic dissections will continue to grow throughout your life. Kind of like your earlobe and your nose and your ear, much to my dismay, considering what I'm starting with, it's very disappointing. But here's the good news. There are many, many patients that I follow in the office that I graduate. What are the numbers? About 50%. So I follow thousands of patients in the office. I see them every year or two, or sometimes even longer, because as they become more stable, I just let it go. And usually, in 50% of these patients, they will stabilize at some level or they will just age out. My favorite story, as I think Karen has heard, is I had an 88-year-old little guy who I saw a few years back, who I said, "You're all right. You won." He said, "Thank you." I said, "You graduated. You can, that's it. We're done." He said, "I'll see you next year." So he comes in the following year, same story. He came in this past year a little more confused than he was in previous years. And I said, "Hey, congratulations, you won." And he said, "Thank you very much." And he walked out the door at age 90 with the aneurysm that he had been followed on for years. Now, I want to talk about this for a second. People in the watch and wait group who are going to have their aorta watch and wait until age 90, I don't think that that's fair. I think that that's brutal and that's rough. So, what can you do to decrease your anxiety and to inject a little reality into the situation? Here is the truth. If you come from a family where there's never been any documentation of aortic rupture, unexplained sudden death, multiple early deaths, things of that nature, you may just live with your aneurysm. Versus if you come from a family where everybody gets a dissection, that's a different gene and a different problem.
I like that. I could take it to heart. This is a really good question.
Well,
So there was a patient of 82 years old, type B dissection. Do you still have your immediate family members checked? I think the misconception is, well, that's just an old aorta and stuff happens.
exactly. And so here's the way I look at here's the way I look at the way that people need to understand this. If you look at the population as a whole and you took all the 80 something year old people and you laid them all out in front of you and you looked at all their medical problems, the number of people that would get a problem with their aorta is really, really small. The number of people that have high blood pressure, diabetes, cancer, heart disease is really, really big. So, what separates the person that gets the dissection from the person that doesn't get the dissection? In my opinion, there is only two possible answers. One is what we've been talking about: genes, genes, genes. What they are, what you got, I can't tell you, but there's something wrong with your genes. But here's the other thing. I did mention if you have significant atherosclerotic disease of the aorta, really, really bad calcium, horrible looking aorta, those aortas can get dissections in them that you probably could ascribe to the the atherosclerotic disease. Yes, but in the overwhelming majority of patients who have atherosclerotic disease, they also don't get dissections. So, what's the harm in just getting checked out? The answer is nothing.
Wouldn't the ultimate goal be just like everybody should have a colonoscopy at a certain age or mammogram at a certain age? Everybody should probably just have an echo or CT at a certain age.
Karen,
Ben?
thank you. So here's where we're getting into the weeds a little bit. The issue of how and when and who should be screened for aortic aneurysms is hotly debated even amongst the group of people who are looking at a population that has aortic aneurysms. We all agree that people need to get surveillance, and we agree that there is definitely a relationship, but we don't know what to do. So I'm going to walk you through a couple of really basic things that everybody's very familiar with. Colonoscopy, mammogram, prostate specific antigen testing. Okay, these are three things on various sides of the street. Breast exam, mammogram, and we can add pap smear, so everybody's got a couple on their side of the street. The actionable rate for those screening programs, all of them are less than 1%, every single one of them. So as of now, the USPSTF, which is the group who certifies screening programs for the United States and forces insurance companies to pay for screening programs, is already supporting programs that have actionable rates that are, less than 1%. But that's 1 out of 100 people. We got 330 million people in the United States. It's a lot of people. Mm-hmm. But here's the kicker. If the data that we acquired in Brooklyn is accurate, which is no less than 4% of the patients have an aorta that definitely needs screening, no question about it. 4% above 4.5 centimeters and more than 10% above 4. So even above 4, I would screen you, but definitely 4.5, no question about it. The actionable rate is unknown. I can't give you the last piece of information that we so desperately want, which is if I follow 10,000 people with aortas at 4.5 centimeters starting at age 40, how many of them will need surgery? We don't have the data. And that puts us in a very, very tough spot. So I follow what we have. I think that what's going to happen is the public is going to kick back hard on this. And I just operated on a gentleman last year who had a calcium score. You've heard of this. You go in, you pay $100. Some of the insurance companies are paying for it. But the calcium score now shows the aorta because the studies are being done in such a good way that they can see the size of the aorta. I've had multiple patients come to me with aortas that are big. I'm following them in the office. So they're picking them up on a calcium score. I think the public opinion is going to shift dramatically, especially as the calcium scoring tests start picking up more and more aneurysms.
And I would think since 2020 that it's going to increase as well, just with the sheer number of CAT scans from COVID. This is a question that Molly asks, and this will be our last question of the night. How common is it to end up having a dissection when you are being monitored? So you find this aneurysm and, people are told often you probably won't dissect unless you have a known condition like Marfan's, Ehlers-Danlos, what have you. But how common is it for somebody that is doing the proper follow-up to end up having a dissection, when they've been doing everything right?
Really tough subject, obviously. Yeah. Really painful subject for all of us in this business, and really painful subject in the last 2 years, as many patients haven't shown up and were unavailable for follow-up because they either died of COVID or they died of their aneurysm. We don't necessarily even know to some degree. My experience, okay, and the numbers that I talk about with people are that the risk of rupture and dissection is less than the risk of surgery, and so we don't operate. You understand? It's a balance. That risk we calculate based on historical data at somewhere around 1, maybe 2%. When it gets up past 5%, we talk about surgery. When it gets past 10%, we strongly recommend surgery. And I hope that we don't have to go higher than that. But when you're in the 1 to 2% range, we do know that patients will have dissections. And in the last couple of years, our colleagues and I have talked about these patients that missed their appointments and then came in. And we've been trying to figure out, based on this data, what to do about it. But the truth is that if you're following 1,000 patients a year, and if those patients return a dissection of 1 or 2 of those patients in that same time frame, that is a statistic that is a very reasonable one to live with, because if you operated on those 1,000 patients, statistically speaking, the risk of death, all comers, is probably between 3 and 5%, depending on how complicated the operation needs to be. Now, certain operations, the risk is down in the 2% range. Other ones are even higher. But it's a balance. It's a balance. So if you're in the watch and wait group, the stress that you feel is not for nothing. But I can't make this go away. All I can do is say, this is the best we got. Take your medications. And until your risk of rupture and dissection is above surgery, you're not getting an operation from me. You can go to some nut job and get it, but you're not getting it from me, because I'm not going to subject you to more risk just because you're stressed out. You'll be a lot more stressed out if something bad happens, and so will your family. And it's just a disaster. We have to avoid people pushing these things in all aspects of medicine just because we can. And I don't know if that makes you feel better, but you have to know that we function within the statistics. We're doing the best we can for you. And we're just trying to amass all the data we can so that we can give you more information from year to year. And that's all we can do.
It seems kind of similar to if colon cancer runs in your family and you're having colonoscopies because it runs in the family, and you have your clean colonoscopy and they say, come back a year later, the same level of stress is going to be there waiting for that year until you can have your test to determine, do you have any polyps? Do you have any unusual, areas in your intestine? It's the same thing. I mean, there really can't be an operation. The risk would be it would be too risky. I mean, you're doing something that doesn't need to be done yet. But if you had polyps that came back precancerous, you might have another discussion if it runs in the family, or high dysplasia cells, or what have you. So, but I can appreciate the nervousness, and I really do appreciate, again, you explaining typically that rate of growth of the millimeter a year, right? Because as you know, I'm in a watch and wait also at 4.8, both at the root and in the thoracic descending. So I had no idea that those numbers could go that high. And I will answer the other person who asked a question about growth. It's been 3 years. I haven't had any. But 4 years ago, I went in 1 year, in less than 1 year, in 6 months, I went up over a centimeter, which I was like, oh, alarms. Everybody started freaking out. I started freaking out, not everybody, not my surgeon, but I was freaking out. And with good blood pressure control, and I'm doing everything that I can do, I haven't seen any growth at all in the last 3 years. So now I don't mind waiting a year for the next scan. Before I was like, no, it's been 3 months. Let's do another scan. Let's scan every day. Yeah, so I get it. I get all that stress. Well, we are not going to take any more questions. I'm so sorry if the last person, and you didn't get yours in there. But if you write them up there, Dr. You'll be more than happy to answer some of them. And you also can email us at info@Aortic Hope and reference this live event. We'll be sure to try to get those questions answered for you. Again, use all of this as a tool to have those conversations with your doctor. Don't forget to like and subscribe. Check out Aortic Bridge and check out Think Aorta, both amazing organizations. Thank you, Ben.
Thank you, Karen. I love doing this, and I look forward to seeing everybody at Rock from the Heart.
Yeah.
In sunny Minneapolis, Minnesota.
Balmy Minnesota at the end of February. Can't wait. we're an American band, right? We're going to rock and roll and have some education and meet lots of people, and it's going to be a good time. But thanks again, Ben. We really appreciate your time and your insight. And as always, it's so great to learn more things from you. So I'll probably talk to you in an hour.
You're welcome. Bye.
Have a wonderful night. Thank you, everybody.